Amit, can you hear me?
Yes, sir, I can hear you.
Yeah, thanks.
Hello.
Yeah, hello. Background में वो PPT.
Hello, madam. Hi. We can hear you and see you as well.
Yeah. And I'm opening the PPT for a minute, if you allow.
Yes, madam. Please. I think we need to give you rights.
That day the platform was different, na?
Yeah.
Yes, sir, already given, sir, rights.
Yeah, sure. Thanks, Amit. So, madam, you have the right, so you can.
Yeah, it's only 5 minutes, so that's okay.
Yeah.
The name of the introduction, I'll read it on this.
Should I keep this on, or you?
The
want to-
PPT should be kept in the background.
No, you just have to click on that and it's open then,
Yeah, I'll
right?
call it.
So right now I'll stop share.
Yeah, stop share.
So when you click here,
yeah.
Sorry.
Yeah,
click here,
that time that
No,
चला गया अभी.
I'll just make sure it's open here.
बैकग्राउंड में ओपन रखना है, बस वो बंद मत करो और अभी सीधा जूम पे चले जाओ, या तो ये बड़ा करो इधर क्लिक करके. हो गया. हाँ, बस हो गया. That is done. So I'll have my lunch in 10 minutes.
Yeah, madam. Please. So
There is 15 minutes का time है ना?
हाँ मैडम, डॉक्टर मैं आया नहीं अब तक. वी विल हैंडल. आपसे तो बात करेंगे.
You send invitation to Niket and Molina.
हाँ मैडम. Yes. We have sent.
I am at a different level. I am in Jaipur right now. So that day also Molina said it was so interesting to listen that.
Dr. Christos has joined. Dr. Christos Benitez.
Hello to him.
Yeah.
Today Jaipur doing procedures in CBI.
Hi, Dr. Christos. Hi.
How are you?
I am good. I'm great. How are you doing?
I'm very well. Very good to see you.
Yes, same here. Pleasure. Yeah, so we are unable to see Dr. Christos.
Yeah, you will be able to see me soon.
Yeah, thanks. Yes, perfect.
Good afternoon. Good afternoon, everybody. Good afternoon, ma'am. Good afternoon, sir. Pleasure to meet
Good
you.
afternoon. Yeah. So Dr. Christos, Dr. Nana Patel has joined. She would be our honorable chairperson for the day. And Dr. Nana Patel, Dr. Christos, when it is from Australia, he's our speaker for the day. So thank you very much for joining, Dr. Christos. It's a pleasure
Hello,
having you
Dr.
today.
Yes.
Thank you, my pleasure. And, I'm very happy to be amongst you today. And I'm looking forward to a very interesting discussion.
Yeah,
Sure.
same here. So Dr. Venitis, a quick brief about the flow of meeting. So I would begin the meeting. I would just take a couple of minutes. I will then introduce Dr. Nana Patel. She's our chairperson for the day. And after that, Dr. Nana Patel is at the contest and she'll introduce you. After that, you can start the session. And after the session is over, Dr. Nana Patel will have a couple of slides of her own experience about biosimilars. And after that, the session will be open for the joint session for Q&A. And we will have a hard stop at 4:30 p.m. IST. So that's already informed.
Fantastic. That's excellent. Thank you.
Yeah. So let's test your slides once. Yeah, looks good. Can you move them? You're on mute. You're not able to hear.
Sorry.
Yeah.
I was just wondering whether you could see the full screen slide.
Yeah,
or
it was
whether-
full screen. It was full screen.
Okay, fantastic. Just making sure
in the
that.
slideshow mode. Yeah.
Yeah, fantastic. Okay.
So all looks good, all set. So Dr. Nana Patel will join us soon. She's just out for lunch. She'll join us in 5 minutes.
That's fine. Excellent. Thank you.
Yeah, it's great to have you today. It's a pleasure.
No, the pleasure is all mine. Thank you. And especially given that communication has not been, let's say, as straightforward as it usually is, but I'm very, very happy to be joining you tonight. It's actually in India, it's like now noon, right? It's 2:30 p.m.
Yeah, 2:30 p.m. IST.
Yeah. Here it's a bit later in Australia, but hopefully the attendees, and is it going to be? I can see it's also broadcasted live on YouTube.
The broadcast is only for our internal employees, so it will not be shared anywhere. It's only for internal market employees, so that they also can listen to and learn from. Mohan, can you please go on mute?
Yeah. Or so much you can make him on mute.
Can I unmute him? I don't know.
Yes, you can unmute.
Yeah, I think someone has that.
Yes.
Yeah. So Dr. Venitis, what's time in Australia now?
Oh, it's like 5 to 8. I think the difference is, about 5.5 hours.
Oh, a big difference.
Yeah.
So you're based out of Sydney or Sydney, no?
Sydney, yeah.
Yeah. Great.
Hello. Good evening, Professor. I'm Dr. Bharat. I'm working closely with Someshwar, and I'm currently heading the fertility therapy area in India. Pleasure meeting you.
The pleasure is mine, Dr. Bharat.
Thanks.
Great. So I think Miranda, right? Miranda Hickey from Australia. Miranda. She might also join us soon. She mentioned that she's also keen to join, listen to lecture. Hopefully she will make it.
Fantastic. That would be great. And there is also a time zone difference with Perth as well.
Yeah.
Sure Miranda is based in Perth. So
yeah, she's based out of Perth. So Perth is 2.5 hours difference from India.
Yeah.
Singapore time Perth is.
Yeah, exactly.
Yeah.
So how many attendees do we expect in total?
So we expect somewhere around 15 from India and 2 from Nepal. So Nepal is an joining country from India. So somewhere around 15, 16 we can expect.
Fantastic. And we're going to start at,
Yeah, we'll start on time. Time.
Yeah. Excellent.
So when Dr. Nana Patel joins, we are good to go.
Hello, Miranda.
I'm on mute. Hi, Christos. Lovely to see you. I'm joining for the first half an hour, so I'm really, really excited to be here. And thanks, guys.
Hi, Miranda. Hi. Good to see
Hi,
you.
Samesh. How are you?
I'm great. Thank you for joining, Miranda. Thank you.
Thanks, Samesh, for the
Pleasure having
invitation.
you
I'm
today.
really looking forward to this, and I haven't seen Christos for quite some time. So should be
Hopefully
good.
soon,
Thanks.
Miranda. Hopefully soon.
Oh, I know. Let's hope so.
Yes.
So we were just discussing about time difference between Perth and Sydney. So it's quite a big country. So big geography, a lot of time zones.
Interestingly, 3 hours between Sydney and Perth, but only 2.5 hours between Perth and India. So
Yeah,
that totally
surprising.
demonstrates the size of the country, of course. Yeah. Hi, Bharat.
Hi, Miranda.
I'll put myself in the background quietly. Have a great meeting, everybody. Really looking forward to it.
Sure.
I'm back. I've seen Dr. Nayana. Hi, Dr. Nayana. Nice to
Dr.
see you
Naina,
again.
she just went for lunch, which will be joining
Oh,
us.
okay. She's not there. Okay.
She joined in. She just took a short break for lunch.
No problem. Late lunch.
It is 2:30 after all in India.
Yeah,
So
that's true. That's true.
it makes sense. How are things with COVID, Miranda, in WA?
Interestingly enough, because we only opened our borders 2 weeks ago, everybody's dropping like flies. Everybody, well, not everybody.
Oh.
It's my neighbours are all in lockdown. The schools are dropping off in lockdown. We're probably a year behind Sydney, I think. I've just been fortunate enough to go to the UK and Germany and came back COVID-free.
Wow.
I'm more at risk now in Perth. We're having about 8,000. So we will probably reach our peak in maybe a week or so. But it's not, all of us will eventually, of course, but it's steady. So it's not been too much of a impact on our health resources.
But the vaccination rates are good now.
Huge.
Yeah, there's a pretty good
rates.
coverage. Yeah, that's good.
And it's been demonstrated it has made a difference.
Okay, that's good.
But I've been trapped in lockdown in Fortress WA for over 2 years. So there's pros and cons. I can't help myself. I'm back again. I can't sit in silence. Christos, thank you very much. I know it's very late on a Friday evening in Sydney.
It's fine, and it's a pleasure. It's truly a pleasure, and I'm really looking forward to a very interesting discussion.
Thank you.
Miranda, are you going to be going to ASHRA this year? So I'll meet you
I was
there.
actually talking with my colleague Bharat earlier today in regard to ESHRE. My flights are booked. I'm going to be there unless there is another variant, which is far too transmissible. But my plan is I will be there.
Yeah.
And I will see you in the gym.
fantastic, as always.
And you'll be going? Yes, of course.
Yeah. You know, SREP is something I actually, again, have a couple of lectures, but even if I didn't, you know, I would still go.
Yeah.
It's a great time to just catch up with so many colleagues and friends in Europe. So.
And the fact that we're moving out, that we can have those connections now. When I caught up with our global medical team, as I say, when I was in Germany, it was so wonderful to all see each other like real 4D people, not on a screen. So it was like, it was really exciting. Everyone was just so pleased to see one another. So nothing beats face to face.
I think it's going to be quite interesting. And you know, how socially awkward it's going to be in the beginning when you first get to physically interact with other people. You know, we used to shake hands, hug. Now I'm not sure whether we'll be keen to jump into that state of you know, interaction again straight away. You know, it would be great if it would happen, but I think there's going to be some you know, people are going to be hesitant.
So very true. And the Europeans are very,
of course, we are
close and contact, and so yeah, it will be interesting.
You know, that's how things you know, go in Europe. Dr. Nayana is here.
Hello,
Dr. Patel, you've had your lunch.
Yeah,
lovely to see you.
Hi, nice to see you, Miranda. Long time.
You too. All's good. Right, I'll leave it to Someshwar now, and I promise I will now be quiet. But lovely to have everybody online.
Yeah. Thank you, madam. So, madam, can you start, madam? So, permission.
So, Vishwar, you want me to start now?
No, I'll start, madam. I'll start. I'll just begin. So we're already 5 minutes past 2:30. So we'll start, madam.
Yes, sure.
Yeah. So I'll share my screen. So I hope my screen is visible.
Yes.
Yeah.
Yes, Someshwar.
Thank you so much. So hello everyone, and a very warm welcome. On behalf of my entire team of Merck, Dr. Someshwar Raisam, welcome you all for this unique EKTL program by Merck. The objective of the EKTL program is to enable our Indian fertility experts to interact with the international experts for addressal of all their queries and doubts around different aspects of troubleshooting around ART cycle. So today we have with us Dr. Naina Patel, who would be our honorable chairperson for the day. And we're also joined by Dr. Strauss Benitez from Australia, who would be our keynote speaker for the day. Thank you very much for joining. Coming to the agenda for the day, so Dr. Naina Patel will set the context, and after that, there would be a lecture on the topic of the case of phytropin alpha originator versus biosimilars, difference beyond individual RCT. So this would be Dr. Christos Benitez, and followed by that, there would be a short local experience session with Dr. Naina Patel on the same topic. Dr. Naina Patel would be sharing her own experiences, which she has done in their own clinic on the same topic of biosimilars and originators. And followed by that session would be then open up for troubleshooting Q&A and discussion session. So in this session, all participants can open up and ask their different queries around different aspects of ART cycle and get all their queries addressed by Dr. Benitez and Dr. Naina Patel. So today we are joined by different pool and elite pool of all fertility experts from India and Nepal. So today we are joined by Dr. Naina Patel from Anand, Dr. Rekha Rani from Karimnagar, Dr. Sindhuma Davalori from Vijayawada, Dr. Kaushiki Ray should be joining us soon from Kolkata, Dr. Partha Ranjan Das from Kolkata, Dr. Shilpa Reddy from Bangalore, Dr. Vaishnavi Rao from Bangalore, Dr. Rukail Fatima from Chennai, Dr. Nivedita from Chennai, Dr. Nalini from Virudhachalam, Dr. Asha Vijay will join us soon from Bangalore, Dr. Smriti Atam already joined from Delhi, Dr. Lina Yadav from Gurugram, Dr. Sangeeta Jain from Delhi, Dr. Monica Sajdev will join us soon from Kanpur, Dr. Madhuri Gandhi from Thane, Mumbai, Dr. Yura Jadeja from Baroda, Dr. Sarika Zunzare from Nanded, Maharashtra, and we are also joined by Dr. Sri Prasad Adhikari from Kathmandu, Nepal, and also Dr. Shweta Singh from Kathmandu from Nepal. So welcome all the participants who are joined from different aspects of the country and also from Nepal. Now, without any further delay, I'd like to welcome and introduce our Honorable Chairperson for the Dr. Nena Patel. So Nena Patel is the Medical Director of Akansha Hospital Research Center from Anand City of Gujarat, India. And she's a well-known figure from India and she does not need any introduction, but it's an honor to welcome Madam on the screen. So she's considered as a pioneer from the field of surrogacy and IVF from India. And Dr. Nena Patel delivered around 158 surrogacy babies till date till 2021 at her center. And she's also the past president of State Society for OBGYN of Gujarat. Nina Patel is also the founder president of Gujarat chapter of ISAR. She will also be awarded with the Shobna Bain A. Shouted Trophy Award in the past by IMA Gujarat for her social work in medical practice. Dr. Nina Patel was also invited at the Oprah Winfrey Show, Hard Talk, TED Talks, and Josh Talk shows. And she runs Anand Surrogate Trust, Saroma, and SRT I Charitable Trust, which works for well-being and betterment of surrogate mothers, their families, and the IVF patients. She also authored a publication, LHN FSH Synergy, a review in the role of COS with all other international experts and global scientists. Nana Patel also on the advisory board panel of Merck, and so it's always an honor to have Madam on board. But Nana Patel is a most sought after speaker and she has delivered numerous lectures at various national and international conferences, and she has authored many articles related to many various topics, research topics. She also has various case report, book chapters, and she authored many textbooks. Her research topics interests are regenerative medicine, gut microbiome, over-inflammatory biomarkers, and PCOS. The documentaries on her work, The Womb of the World, were telecasted in the National Geographic Channel, and House of Surrogates were telecasted at the BBC. So with this, I request Dr. Nina Patel to kindly set the context and welcome our speaker, Dr. Christos Benitez. Thank you. Thank you for joining.
Thank you, Dr. Someshwar. And thanks, Merck, for having this webinar and having me over here. I welcome Dr. Christos and Miranda. Dr. Christos, who's going to talk to us on today, the biosimilars versus the originator gonal-F, the case scenarios. He is a consultant gynecologist and fertility specialist, and also an associate professor of the University of New South Wales and director of clinical research for IVF Australia. He has attracted many fundings, up to $1.5 million in last 5 years, and has used it for the researchers worldwide in obstetrics and reproductive medicine for 2020, and an author of more than 100 publications in international scientific journals. Also, he has been a passionate advocate of evidence-based medicine in his field and has been serving as a member of the editorial board of Human Reproduction since 2008. Also currently a section editor for RBM Online, Reproductive Biology and Endocrinology, and associate editor for Reproductive Sciences and Fertility and for Fertility and Reproduction. His research interest includes ovarian stimulation, endometrial receptivity, reproductive epidemiology, and the health of mothers and babies after ART. He is currently leading a number of research projects in these fields, both nationally and internationally, and is mentoring junior colleagues. And I have had many opportunities to hear him, and I know all our panelists whom I welcome over here for this meet, that they would have a wonderful experience from what knowledge he is going to share with us today. So over to you, Dr. Christos.
Thank you. Thank you, Dr. Patel, for your very kind introduction. And thanks to Merck for their invitation to be part of this forum. It's truly a great privilege and pleasure to be amongst such a collection of esteemed colleagues from India. And I'm very happy to have this discussion on the proposed topic. And hopefully we'll be able to continue with some interesting cases from Dr. Patel. So I was asked today to have, to prepare a presentation on some recent work we've done on folitropin alpha originator and the biosimilars. And what I would like specifically to talk about is when individual RCTs might not be enough and where differences might, actually exist. So I would like, first of all, to start by disclosing my potential COIs. And I would like to start this discussion by just acknowledging the obvious, that control of iron hyperstimulation is nothing new with gonadotropins. And it was reintroduced in the early 80s. And many of us do not really know the story, but it was actually Georgiana Jones, the partner of Howard Jones and also esteemed researcher, that while they were trying to create the first baby in USA, they realized that Clomid potentially was not good enough. And Georgiana suggested that they should go back to HMG, which they had used way before the birth of Louise Brown, but they had abandoned at the time. So they moved on to start using HMG again. And the story is well known. Elizabeth Carr was born a few months after that. And the rest, I guess, is history. So ovarian stimulation with gonadotropins is something that we've all been taught through our very first exposure to ART and to IVF. And this is a famous graph by Bart Fauser and colleagues published in The Lancet, which essentially describes what ovarian stimulation is doing, where essentially is prolonging the window of recruitment and therefore counteracts the natural selection mechanisms that occur during normal reproductive physiology and monoovulatory cycles. So by doing so, we are able to drive and to stimulate the growth of more than one follicles. And therefore, follicles that otherwise would be led to atresia now can actually be recruited and collected. So it is rather interesting if you actually look at what we're doing. One could very well say that what we're doing is we're not stimulating the ovary, but what we're essentially doing is we're rescuing follicles from atresia. But that doesn't have so much importance eventually, because the reason we do it is to collect multiple eggs. And why do we need multiple eggs? Why wouldn't one egg just suffice? Well, obviously, because we do know that the number of eggs is positively associated with both the number of euploid embryos, both the number of good quality embryos, but also eventually the number of pregnancies that you get from a single stimulated cycle. This is a recent study we did with my colleagues, including the ANZR data, which is essentially a population-wide registry that captures all ART cycles in Australia and New Zealand. And by using the ANZR data, we were not alone. There were many others using other data sets that have shown very similar findings. But we very clearly showed that the more eggs you have, the higher the chance that at least one live birth will be produced by that cycle. And obviously that effect is not uniform across all age groups. We do know that, for example, younger women, younger than 34, probably saturate at around 20 to 25 eggs. Women about 35 to 39, 40 potentially can benefit even with greater numbers. Whereas for women 40 or older, as you can see with the green line, the numbers are actually, the probability is far smaller of getting a live birth. However, there's still a trend for an increase as you increase the number of eggs obtained. So that's how, ovarian stimulation using gonadotropins was introduced close to 4 decades ago. And of course, we all know gonadotropins, again, a basic topic whenever we, any of us started their exposure to reproductive physiology. We know that in the late 20s, we had the discovery of the FSH and LH. And in the late 50s, after a lot of research, we had the first extraction of gonadotropins from a human pituitary. And a couple of years later, we were actually able to identify urinary gonadotropins. Probably one of the greatest milestones in the era and in the field of ovarian stimulation was the introduction of recombinant gonadotropins. And the first ones were folitropin alpha and folitropin beta. Since then, obviously, we had long-acting folitropin, chorefolitropin, we had folitropin delta. Now we also have folitropin epsilon, and so on and so on. Someone might ask, why did we feel the need to go recombinant? Well, because first of all, the urinary products were not pure. They had a good number of other proteins that obviously pose certain risks. Recombinant products can have more than 99% purity. They offer an endless and reliable source of gonadotropins. There is a very good batch-to-batch consistency, far greater than anything that could be produced with the urinary gonadotropins. They allow subcutaneous administration, which is preferred by most patients compared to intramuscular. And we don't really have concerns regarding transmission of diseases, as they are not products that come from other humans. So biosimilars were introduced a few years later. And many of you might know what the biosimilars are, but many of you might not exactly know what the biosimilars are. And that's the reason why I've included this slide. So biosimilars, and this is according to the definition used by the European Medicines Agency, are medicinal products that contain a version of the active substance of an already authorized original biological medicinal product, which is called usually the reference medicinal product or the originator. Biosimilars are not identical molecules, obviously. They're not bioidenticals, they're biosimilars. That means they're similar but different, slightly different. And these differences can be in strength, in purity. Sometimes they can contain different composition of isoforms or different glycosylation profiles. And that can then lead to alterations in clinical efficacy or safety. In order to prove that a certain version of a molecule is biosimilar, again, according to the European Medicines Agency, you need to prove the similarity in terms of quality characteristics, biological activity, safety, and efficacy. And usually that needs to be shown based on comprehensive comparability studies before it can be approved for use. And this is how things have been working so far in the industry. Many biosimilars have been introduced after their sponsors, the companies that actually wanted to market them, made sure they have enough randomized evidence in order to pursue to prove that they are biosimilars and therefore be granted authorization in certain markets. But the key question we had, and that was a question we had a couple of years ago, is yes, they're similar, but how similar are they? So the question we had is, based on the best available evidence, are biosimilars of folitropin alpha comparable to the originator in terms of live birth rates? Because at the end of the day, I know we're talking about surrogate outcomes, and I know that the main purpose of ovarian stimulation is the number of eggs. But at the same time, what the patients really care about is live birth. So it only makes sense if we are to assess their similarity, we have to go all the way to the key outcome of interest, which is live birth rate. So in order to address that question, obviously one could design a new RCT, spend a few €100,000 most likely, or even more, recruit patients, and after 1 to 2 years, they might have had yet another RCT suggesting whether the result is favorable or not. However, we knew that there were already a number of RCTs that had been published as part of these biosimilars obtaining approval. Therefore, we felt that it was sensible, before we move on and potentially discuss whether it would be useful to design an RCT, it would be sensible just to go back and look at the evidence, look at the data. The data might already be enough to prove that the biosimilars are indeed comparable to the originator. So we embarked on performing a systematic review and meta-analysis, which actually was designed and reported according to the strictest of guidelines, according to the PRISMA guidelines. It's important to note that this was a systematic review that was registered in the Prospero, and it was registered a priori before actually starting the project. So there is full transparency of the methods that we were about to employ. We performed literature searches on electronic databases and also clinical trial registries globally. And we also looked at conference abstracts and tried to find RCTs that compared biosimilars of folitropin alpha with its originator. We searched up to the 31st of October 2020. We included studies in English, human studies, and any duplicates were removed. And of course, we assessed all the individual studies for risk of bias, and that was done independently by 2 authors using well-validated methods proposed and supported by the Cochrane Library. What was the primary outcome measure? As we said, trying to remain true to our cause, which is, let's see whether the biosimilarity is such that does not affect the key outcome measure, which is a live birth. The primary outcome measure was a live birth rate per randomized patient, and that was defined as the number of deliveries with at least 1 live birth, resulting from one aspirated treatment cycle, but that included both fresh and frozen transfers. So this is probably a more modern way of evaluating the effect of any intervention during ovarian stimulation by not just limiting your observation during the fresh embryo transfer, but extending it all the way to all the embryos that have been produced by that single stimulation cycle until a live birth is achieved or until you have transferred all embryos and the woman is still not pregnant. So all the multiples were registered as a single delivery, and we use data from only first stimulation cycles. And I say that because some studies, as you will see later, actually included 2 or 3 cycles. These cycles, multiple cycles, were used to define different outcomes. If we go to the secondary outcome measures, clinical pregnancy rate was another outcome measure, ongoing pregnancy rate, and obviously we evaluated everything that would be sensible when you're trying to compare it to different modes of stimulation, and that's the total dose of gonadotropins, the duration, the number of oocytes retrieved, and of course OHSS. Let's not forget about OHSS. Safety is equally important, if not more important, for many patients. So this is just a chart, the PRISMA flow chart, suggesting how we scrutinized literature. As you can see, we had about 292 studies originally retrieved through our search strategy. And after scrutinizing and perusing the titles, the abstract, and eventually the full text, we ended up with 5 RCTs that fulfilled the criteria for the systematic review and meta-analysis. So what are these 5 RCTs? Here you can see them based on the type of biosimilar they have evaluated, but also the clinical trial registration. And as you can see in this table, the size varied widely, the smallest being about 110, and the largest being more than 1,100. The method of randomization was in 4 out of 5 cases computer algorithm, and for 1 was not reported. There was blinding, but in all cases was single blinded. And again, 4 out of 5 studies, if you see, they were powered and they had as a primary outcome measure the number of oocytes retrieved. And it was only 1 study, the largest obviously, that was powered and had as a primary outcome measure the clinical pregnancy rates. And someone might ask, why was that? Well, because if you remember, these were all studies that were essentially run, organized by the sponsors of certain biosimilars who wanted to prove biosimilarity. And according to the regulatory authorities, that meant that the primary outcome measure needed to be COCs. The equivalence or the biosimilarity had to be proven on the basis of equivalence between the biosimilars, excuse me, and the originator in terms of number of oocytes retrieved or cumulus oocyte complexes retrieved. Again, looking at the second table, you can see that we had a mixed bag, both agonist and antagonist protocols. The starting dose was what I would consider, most of us think it's the normal starting dose, anywhere between 150 and 225. I think that's the normal starting dose for a normal responding patients. There were dose adjustments, and these are described in the table. And as you can see, some studies included just 1 stimulation cycle and 1 collection. Some studies included more. And of course, as I said, when they did include more, we only used the outcomes from those cycles from some cumulative outcome measures. In the primary outcome measure, we always used the outcome of the first stimulation cycle and subsequent embryo transfers. So let's go straight away to the data. What's the live birth per randomized patient? As you can see here, we have we essentially have 4 studies contributing with close to 1,900 patients. And as you can see, the relative risk is 0.83 with a confidence interval not crossing 1, which means that the biosimilars, based on the meta-analysis of the available randomized data, were associated with reduced probability of live birth per randomized patient compared to the originator of folitropin alpha. And I know many of you might be surprised, but we were equally surprised when we saw the results. But that is what the data tell us. What about ongoing pregnancy per randomized patient? Is the effect consistent? Again, very, very clearly, you can see previously the relative risk was 0.83. Here, the relative risk is 0.81. and the confidence interval spans from 0.68 to 0.96, meaning again, there is a statistically significant difference in terms of ongoing pregnancy rates per randomized patient in favor of the originator of folitropin alpha compared to the biosimilars. Clinical pregnancy rate, very, very similar results. You can see here relative risk 0.82, again, statistically significant. What about the cumulative pregnancy rates? And as I said, these are outcome measures where indeed we used more than one stimulation cycles, surprisingly similar to what we have observed. In terms of cumulative live birth, you can see that the relative risk is 0.85, again, statistically significant, implying and suggesting reduced cumulative live birth rates in the biosimilars compared to the originator. Similarly, for cumulative clinical pregnancy, and it's only in the cumulative ongoing where, although the relative risk is still trending to 0.80 something, this time the confidence interval is wide and therefore it's not statistically significant. What about secondary outcome measures? So as I said, ovarian hyperstimulation syndrome is always a huge consideration when we're evaluating any type of ovarian stimulation. As you can see here, the relative risk 1.04, very wide confidence interval. I think it is quite obvious that it doesn't appear that there is a difference between the biosimilars and the originator of folitropin alpha in terms of OH success rates. Let's look at other stimulation characteristics. The total dose of gonadotrophins. So the mean dose was reduced by 37.5 units, so half an ampule, if we're going to talk about 75 IUs ampules. And that was not statistically significant because, as you can see, it barely crosses zero. The number of oocytes retrieved, interestingly, there were statistically more in the group of the biosimilars compared to the group of the originator, and that wasn't a small difference. It was up close to 2 COCs retrieved, which we found very intriguing, and I will discuss a bit later. In terms of the duration of stimulation, we saw that there was a statistically significant difference in terms of the duration of stimulation in favor of the biosimilars. So based on this, even though the total dose of gonadotrophins is not statistically significant, and therefore we do not have conclusive evidence, one could deduct that the biosimilars seem to push harder and seem to exert, let's say, a higher stimulatory effect on the ovaries. But what we were really, really intrigued by was that number of oocytes retrieved. And we felt that that's very intriguing. Why? Because as we've seen previously, when you do have a higher number of oocytes retrieved, one would expect that you would have a higher number of live birth rates. But that's not what we observed here. So we actually went back and we started scrutinizing again all our data. And one of the things we realized, and unfortunately that was after we had published, and therefore we're now in the process of submitting an erratum, we saw that one of the studies, this one, the Folitrop study, the last one, as you can see, although every other study seems to be similar and has quite wide confidence interval, this study has unrealistically small confidence interval. This is not something that we would expect. And what we suspected was happening is that the standard deviation, which as you can see here, ranges somewhere between 5 and 7, 7.5. For some reason, these authors reported that the standard deviation was 0.5 and 0.9. So we actually have a theory, and we feel that that is incorrect. And what the authors have actually reported is the standard error of the mean, which is far more likely to be the case, because if we then convert the standard error to the mean to standard deviation, you can see that now the standard deviation is about 9 and 9.4, which is far closer to what would be expected compared to every other randomized control trial. So if that is indeed the case, and this is of course something theoretical, then essentially there is no difference between the studies in terms of number of eggs retrieved, in terms of when you compare biosimilars with the originator. And importantly, we can see that all studies now seem to agree. The heterogeneity now becomes 0%. whereas I'll go back just to show you, previously it was close to 90%. So for us, this seems far more likely and plausible scenario, but obviously we'll have to hear what the authors of that study have to say. Currently, we have not been able to get their feedback. So that's what the meta-analysis showed. And some, as I said, some like you might already be discussing why is that, why the difference is there. So as we already said, they're biosimilar. So FSH from FSH might differ. In what way? We know there are FSH isoforms and that not all isoforms are the same. There are different naturally occurring isoforms of FSH in nature. We know that like premenopausal women have, or menopausal women have a significantly different isoform compared to women, young women of reproductive age. But even during the cycle, the actual cycle of a woman, we'll see different type of isoforms actually being more prevalent. So we know that the FSH has up to 4 glycosylation sites, and these NN glycans can then be further charged with sialic acid or sulfate. And the more sialic acid molecules we have, the longer the half-life will be, but at the same time, there's going to be a lower in vitro biological activity. And just to make this, to simplify this, the more complex the molecule is, because we have more sialic acid and therefore more acidic forms, the more complex the molecule is, the more difficult its clearance from the circulation is. So it stays in the bloodstream longer. But at the same time, in vitro, when you examine how strong it can actually bind the FSH receptor, the more complex the molecule is, the harder it is in a way to go and bind with the FSH receptor. So let's go now to the actual studies. Biosimilars versus originator. This is Bemfola, a known biosimilar, and compared with the originator, which is GONAL-F, of course. And as you can see, it had a different profile of glycosylation with a much higher proportion of isoforms with tri or tetrasilated. So that meant it was much higher, much more acidic, and that led eventually to higher in vivo bioactivity. And be careful, this is now in vivo, not in vitro. And why someone might say the Christos, the in vivo bioactivity is higher when you just told us that the more complex molecules cannot connect with the receptors in the same way? Well, because the fact that the clearance is much, much lower means that the concentrations in the blood actually remain at a higher level for longer. So as you can see here, the average bioactivity of Bemfola in this study was about 106% compared to 97.3% of GONAL-F compared to the nominal values, the values that we were expecting. Other interesting observation from that study is the batch-to-batch consistency. The coefficient of variation was significantly different between the two molecules, and Bemfola had a higher coefficient of variation with GONAL-F, where the variation was much smaller. What about real-world evidence? And I will be concluding my presentation, because meta-analyses are great and RCTs are great, but many times people actually wonder whether the real-world evidence can back up what we see in RCTs. Sometimes, and I've had this discussion many times with colleagues, RCTs do not necessarily reflect our experience or what we see in clinical practice. And the explanations could be numerous. Like, for example, RCTs are very restrictive and include patients that are very hard to find in real world, where we know we have complex patients with multiple comorbidities. So whenever you do a meta-analysis based on randomized control evidence, it's always good to see, what about real world evidence? Do they seem to back up what we found? So this is a very interesting study which has been announced just last year at ESHRE, and we're eagerly awaiting its publication. And it's a non-interventional observational study, essentially, from the French National Health System, which included databases, linked databases from the National Healthcare Insurance Database, the Outpatient Healthcare Consumption Data, Medication, and the Hospital Discharge Database. And that's an exhaustive medical administrative database which covered 99% of the French population, around 68 million. So this is what we call big data. So this was a study that covered from the 1st of the 1st, 2013 until the 31st of the 12th, 2017. And it included 135,000 women who had undergone about 214,000 cycles. So the question these authors asked is, how effective is assisted reproductive technology in terms of cumulative live birth rate in France, depending on the gonadotrophin used? And it's a very interesting publication. It has many different comparisons, but I would just like to show you when they compared originator of folitropin alpha with the biosimilars, what they could see is the adjusted hazard ratio for cumulative live birth rate was 0.84. And that meant that there was a 16% lower relative chance of live birth with biosimilar. And that, of course, was highly statistically significant given the mere size of these studies. So it's very interesting, and it's almost, a fascinating coincidence how even the effect sizes seem to be very similar from randomized controlled trials and from real-world evidence. They also compared severe OHSS, and as you can see, there was no real difference between the two groups compared. So the limitations of the study, of course, and they should always be mentioned, is that they included only cycles with oocyte pickup. So any cycles with cancellation for any reason, including, let's say, risk of OHSS or poor ovarian response, were not included there because they were not present in the databases. There were no data regarding the ovarian reserve of its individual patient. And the biosimilars were only available since 2015. And therefore, all the results should be interpreted with caution. And that's always the case when we look at big data studies. But as I said, we're not trying to draw definitive conclusions on the basis of a registry study, but we're trying to see whether it seems to be corroborating the evidence we have from high quality RCTs. Some people then might say, and this is my final section, well, certainly, Dr. Vanetis, we understand that there might be a slight difference in terms of pregnancy rates. And yes, whether it's slight or not, that again is something up for discussion. But what about the cost? They might actually be far more cost efficient than the originator. So as you would expect, studies have already been performed. And most of us who have done at least one cost effectiveness analysis in our lives know that they're very specific to the setting they actually are hypothesized to be performed. So I'm going to present to you the settings that we have available. This is again a cost effectiveness analysis in France, and they've calculated the incremental cost, the efficacy, and the incremental cost effectiveness ratio. And as you can see, based on this data, it's clear that the originator of the reference product of folitropin alpha is actually cost effective compared to its biosimilars, means that it leads to higher pregnancy rates at an acceptable cost. And that's irrespective of the incidence of OHSS. What about Germany, another European country? Again, you can see here with a dark blue is the cost of the originator, and with a light blue is the cost of the recombinant FSH biosimilar per live birth. Again, based on this study, the originator seems to be cost effective compared to the biosimilars of folitropin alpha. Finally, in the Spanish setting, this is a study we recently performed ourselves. Again, a very, very similar finding. The reference product was indeed cost effective when you consider the difference in efficacy compared to the biosimilars. So all three cost effectiveness studies that have been published in 3 different European systems, and yes, that's a limitation of those studies, that they all belong in the same continent, seem to support that the originator of folitropin alpha is actually cost effective compared to the biosimilars and not the other way around. So, dear colleagues, dear friends, I would like to conclude, and hopefully we're going to have a pretty interesting discussion, that the meta-analysis of published RCTs comparing biosimilars of folitropin alpha with their originator suggests strongly that there is lower live birth rates over the first or over multiple stimulation cycles in women who have used biosimilars. These findings seem to be confirmed using also real-world evidence. The biosimilars we know can vary from the originator in terms of biopotency and batch-to-batch consistency. And in 3 different cost-effectiveness studies, the originator of folitropin alpha actually was more cost-effective compared to the biosimilars. Of course, that does not mean we have a definitive answer to the question. I do think that based on these findings, further studies are warranted, and are warranted in order to confirm or rebut these findings, and importantly, to identify the pathophysiological reasons for the observed differences, which are not yet entirely clear. They're mostly hypothesized. So probably that would be the next step in further evaluating this interesting research question. And with that, I would like to thank you for your attention. And as I said, I'm very much looking forward to the discussion we're going to have. Thank you.
Thank you, Dr. Christos. That was an excellent presentation. And I'm sure all the panelists, for them, it would have been an eye-opener. Like even I myself, when I analyzed the data retrospectively, which I'm going to present now, it was really an eye-opener for me when I started analyzing my data, which I'm going to present in just 5 minutes, which we had presented as a poster in the Indian Fertility Society annual conference this year. And just sharing it, yeah. So we also thought of coming out with the analysis of, we in India naturally use a lot of biosimilars, and the cost factor is one such thing that comes. So when you covered your topic with all the evidences right from the action level of how it differs between the originator and the biosimilars to the outcomes, the surrogate markers, and the cost effect. So India, being a country where cost is considered as IVF is mainly funded by patients themselves and not from any insurance company, we would look into the cost. And that's why we used to divide our patients where somewhere we can use the biosimilars when they are not very affording. So when I got this idea of analyzing the patients, that what could be the real difference, whether we are spending more on the originators and whether can we get the same result with the biosimilars, where I spend more. So we compared the live birth rate in participants undergoing IVF with Gonal-f and the biosimilars. The patients were from 2016 to 2020, and this was our individual tertiary assisted conception unit. The study population were mainly women undergoing IVF who were administered either the biosimilar or Gonal-f. A total of 174 were given Gonal-f and 190 patients were given biosimilars, and they were analyzed. So this was just a retrospective cohort of 364 where even fresh transfers, frozen transfers were included, blastocyst transfer as well as cleavage transfer were also included. And the main outcome we measured were clinical pregnancy rate, miscarriage rate, even preterm birth deliveries, healthy babies, that is term life with appropriate weight and no congenital anomaly. And the statistic analysis was done using the chi-square. So we found out that in both these cohorts, the age group was almost similar. In the Gonal-f, it was 32.5 versus 30 years in the biosimilar. The AMH was 4.20 nanogram per ml in the Gonal-f versus 5.15 in biosimilar. And the dosage, as you said, we also used a marginally higher donor in the Gonal-f, which was 2870 IU versus 2600 in the biosimilar group. The number of oocytes were comparable with 13 in Gonal-f groups versus 14.5. So a difference of one oocyte, which was higher in the biosimilar group. And the embryos that were formed, both in the cleavage and the blastocyst stage, were in the Gonal-f, it was one embryo higher, 4.34 versus 3.46. But what was surprising was the clinical pregnancy rate, which was higher in the Gonal-f originator group, which was 56% versus 40% in the biosimilars. The full-term live birth rate was 39% in the originator versus 27% in the biosimilars. And more importantly, what we are very interested in having good quality embryos. Both the cleavage and the blastocyst stage were 83% in the Gonal-f originator group versus the biosimilar, which was just 69%. Though the clinical miscarriage rate was comparable in both the group, the other interesting thing that normally we feel that the Gonal-f or the originator we will use for patients who are affording or patients who have a little lower reserve or advanced age. So we thought of segregating this analysis into two groups. Group A consisted of patients who were less than 35 years And group B consisted of patients who were more than 35 years. And to our surprise, even the patients with less than 35 years age had a better advantage with the originator than the biosimilar. So if we see less than 35 years group, in the GONAL-F, we had 4.3 embryos compared to biosimilar 3.16. And the number of embryo transferred were almost the same, but the good quality embryos with the originator GONAL-F was 82% compared to 68 with the biosimilar, and the positive clinical pregnancy rate was 55% compared to 40. This we are talking of patients less than 35 years, and the live birth rate was nearly double, 40%, 40.8% for the GONAL-F versus the 26% in the biosimilar group. So this current study has demonstrated the effectiveness. It is not retrospective analysis of the clinical pregnancy rate and live birth rate of originator follitropin alpha treatment over its biosimilar. And even after having similar number of oocytes, or maybe even one more with biosimilar, the pregnancy and live birth rate was higher in the GONAL-F group. And more importantly, the younger age group, because we always feel in the younger age, any gonadotrophin would work. It's not that. The younger age group are also benefited more from the GONAL-F treatment. And so with this, this analysis that we have done, I have already described the group A, group B, and I end my presentation over here with this conclusion so that we can have the questions from the panelists. I'm sure they may be having lots of questions for you and their answers can be given. So it's open for discussion. Any one of you can start. Somebody, if you have a question, you can just raise your hand, put it on the chat box also. I myself want to ask you, Dr. Christos, that whenever you are selecting a gonadotrophin for a patient, what is the first thing that comes to your mind? You look at the age, AMH, basal enteral count, past performance, whatever. But what is the first thing that comes to your mind that this is the gonadotrophin I would want to start in my patient?
It's an interesting question. And it's, those things that you cannot actually pinpoint why some of us have certain, let's say, we favor certain gonadotrophins over the others. I think it would be a combination of obviously the evidence you have regarding its efficacy and safety, combined with your personal experiences. And one thing I would never discount is also the patient's preference. And why do I say that? Because in Australia, we're very fortunate where in many, like most patients actually would have their medication paid by the government through Medicare. But there are scenarios and models like when, for example, women come for egg freezing, for social egg freezing, without having a specific infertility factor, where they're paying everything themselves. And in that situation, the cost factor is a big issue. And I will also admit that for years, I was using biosimilar in these women. Why? Because I was trying to make sure that I reduce the cost. You always want to make sure you do the very best for patients. And again, not, at least at that point in time, not having the data that I have now, I was feeling that that was the right choice for them, trying to ease the financial burden and at the same time get a good response and hopefully freeze a good number of eggs. In Australia, interestingly, when the doctor proposes something, many times women will have their own opinion. I'm not sure whether it's the same in India. And that means some women might have, for example, prior experiences with gonadotrophins, and they might say, oh, I actually like, gonadotrophin A, I didn't like gonadotrophin B, it didn't work well with me, I was very emotional, or the cycle that I had in the previous clinic was really bad with that gonadotrophin, and now I would like to try something different. And of course, as doctors, we know that in most cases, gonadotrophins do not have such a huge impact. Having said that, I just showed you evidence suggesting otherwise, suggesting that we're actually, I think, moving now from a specific phase where we thought that more or less all gonadotrophins are the same, to identifying that they probably don't work the same for all people. And there is quite some room for individualization on the basis of what can work best for each patient. So I know I just digressed a bit, but I think I find what you just said such a fascinating question, because it's a question I ask myself many times, and a question I ask my colleagues. And I'm not sure, as I said, I have a very specific short answer. It's a combination of things. But I would be very interested to hear your view. What is the first thing you think about when you're choosing the gonadotrophin for a specific woman or a specific couple?
Well, as I said, we'll look into all the parameters, and I would definitely be inclined to use the originator unless I have a report from the patient where she was not happy, or the cost is an inhibiting factor, or I think she would require a higher dosage and the cost will increase. Rather than add a recombinant FSH-LH, just go to the HMG. So these are the factors, but definitely somehow I'm always pro using the recombinant versus the urinary or highly purified. And that is from experience.
And Dr. Patel, since, whenever patients are paying, usually, as you know, and we are consumers as well, we want the original. I'm not sure whether that's, something that is, let's say, part of consumerism. But when you're paying, you want to make sure you get the original. You don't want to get something that potentially looks or tries to imitate the original. Many times, patients will say, "Look, I'm paying thousands and thousands of dollars, saving myself $500 and thinking that I got not the original product is not what I want to do. So please just prescribe the original and don't worry about the cost." So these are discussions that we do have with patients in Australia when it comes to, discussing what type of gonadotrophin we're going to prescribe.
That's very.
But I would be very interested to hear also the panel members, whether they have the same views or the same experiences, or whether there is something else that we might have not identified that's a big contributor to the selection of gonadotrophin.
Yeah, surely. Doctor, you would like to ask Rekha? Can unmute yourself?
Yes, ma'am. Hello, Dr. Christos, and hello, Dr. Naini, ma'am. I'm very much new into the IVF, ma'am, and with this small exposure to the stimulation, actually I started with Gonalef because it was an originator. I didn't want to take any chance. But what I felt is the rate of growth of follicles were very less in the starting, the early days of the stimulation when compared to the biosimilars. So what do you say regarding this, the rate of growth of follicles?
It's an interesting, again, I wouldn't say that I personally have observed, I haven't compared the data in terms of the rate of follicle. I find this a very fascinating observation. I personally haven't made one, but it's not because it's not there. It's because I haven't actually looked. So now that you told me, I'm actually quite intrigued, and I might get one of my PhD students to just crunch the numbers and look at the data. That's a very interesting observation. So am I interpreting your statement correctly by saying that the biosimilars seem to have a more accelerated growth phase in the early days compared to the originator? Is that what you have observed in your personal experience?
Yes, on the 5th or 6th day, basically, I see the rate of growth is very much difference between the biosimilar and originator. Originator has a little bit of delayed growth, but whatever the end result, clinical pregnancy rate has what Naini ma'am told. I even got pregnancies with originator only. But this rate of growth is little bit disturbing for us newcomers.
So was it a lower dose that you started? Sorry, Christos, you go ahead.
No, please, no.
My question to her is that two things I would like to find out. When these patients were showing slower growth, was it a lower dosage of originator that you started with, or the patient was having a higher BMI and you think that she needed something different, an addition of LH, whatever it is? And the same patient, did you rescue it by adding any LH on day 6 or increasing the dose of originator?
Yes, ma'am. Actually, what I have taken is a similar patients, like similar BMI and nearby ages. And when I have seen comparison, I felt like that the originator had a little bit of slow rate of growth. And obviously, on the 6th day, I was afraid and started my LH to increase it. So that's the only finding I had.
That's a very interesting finding, and one could say that it does seem to fit the model that we have, which says essentially that most of the biosimilars are more acidic, and therefore they would be more biopotent in the blood Therefore, that might explain what you're observing. But again, as I said, very, very interesting observation. And I'm very open to these observations, and I'm equally fascinated by the excellent data that Dr. Patel shared, because I do think that the effect is real and that the effect that I've presented to you is there. I just cannot fully explain it. And in science, as you know, we always want to make sure that we find the explanation. So the evidence that Dr. Patel presented in regards to the different embryo quality, which were not present in the studies, in the RCTs that we analyzed, might actually be key to interpreting the differences, the observed differences in pregnancy rates. So I think it's very important to share this knowledge and these experiences, because the more we do that, the more likely it is to identify something that will allow us to explain the observed findings. And when you do explain these findings, then you can be yourself more confident that, you know what, it's not just a coincidence. This is how this works, and this is why this effect is present. And that and I've had that discussion also with companies that market biosimilars. I said it would be to your best interest to identify why this difference is there. Why? Because then you can tweak your molecules, and you can ensure that if there is a difference there, or if there is some type of deficiency, you can essentially fix it, and then you can have a product that will no longer be deficient or be inferior in terms of live birth rates.
Maybe, Christos, it could be because the originator had done a lot more R&D on this molecule compared to the biosimilars, which just jump onto it with the knowledge that they get from the originator manufacturing. Could be that.
Absolutely. And that is, again, a hypothesis, the fact that the molecules seem the same, but they're not produced by the same cell lines. And when the cell lines, as we know with recombinant DNA technology, when they do produce certain molecules, they might change how the molecule actually is formed, the stereoscopic image. All these things might make a difference. And as I said, when you start the journey in reproductive physiology, you hear about FSH, about subunits, and you feel that you know everything. And then when you start diving into more hardcore biochemistry of these molecules, you all of a sudden realize that there are so many things you absolutely had no idea about, and which could be very, very important. So yeah, I agree with you. That very well might be the explanation. It's just that, as I said, as a scientist, clinician, someone who looks always for the truth, I want to be able not to say, oh, this is the likely scenario, but to say, this is what we now know is the difference between the molecules, and the difference that explains all other differences, the clinical difference that we've observed.
Sure. So any other panelists, we would be more than happy to have your experience, like the doctor shared her experience, that how she is hesitating using a costly drug and not getting a proper response on day 6. So any of the panelists would like to ask anything to Dr. Christos regarding this important stimulation thing, because whenever we have students for training at our center, all they want to learn is the stimulation protocol. We are still not confident about the stimulation protocol. Ultimately, they feel that everything is the same and we can use this gonadotrophin, and ICOS is not in their mind, individualized controlled ovarian stimulation. I had a doctor with me. He had started a cycle on his own for a patient on HMG. We got about 8 embryos. First transfer fresh failed, the second failed. And then he was wondering that I've just started and this is happening. I said, what gonadotrophin? He said, HMG. I said, just give 2 months break. Start with the Gonalef next cycle. And believe me, the next cycle with the first transfer, the patient conceived and already delivered. That was the only tip I gave him. So in the initial period, the newcomers would want to start a cheaper drug so that it's not very costly for the patients. They might not be getting very affording patients and they will jump onto HMG. But if they wait and ask the patient to collect some more money and come in 2 months, definitely this the originator Gonalef has a better outcome. So I'm seeing Vishwesh, Monica, nobody is asking any question. Dr. Yeah, please go ahead.
Good afternoon, madam. I'm Dr. Nivedita from the High Fertility Clinic, Chennai. I just want to share my small experience. One of my colleagues, she was a doctor. She basically had one IVF cycle at a place where she was working, and they had used biosimilars. She had a fresh day 3 transfer. She had a pregnancy. Unfortunately, it was a miscarriage at 6 weeks. Then when she came with me, since I wanted to do something better for her, I had started, she was a very low risk. Her AMH was only 0.7. I had started her on Gonalef, but I usually follow a combined protocol of giving Gonalef as well as Menopure, madam. So I follow that kind of a protocol where I gave her 225 Gonalef and 150 Menopure because I use a maximum dose of 370. And with that cycle, she had around 7 or 8 oocytes and 2 blasts she got, which were like grade 3 blast. They were not very good, but we had them frozen. Since her reserve was less, I had counseled her for a pull-up cycle. And then being her doctor herself, she was telling the injections are too costly. I already had 2 cycles. Next cycle, can I go for something less costlier? It was her suggestion to me. She was a rheumatologist. So then I told her, okay, since one cycle I have used Gonalef, the second cycle I went in for the biosimilar, which we have here. And that cycle, I went for a long protocol. The first was an Antac protocol. In the second cycle, it was a long protocol where I had triggered her with HCG. And to my surprise, it was all empty follicles. I usually do a check of all the HCG post-trigger also. Everything was there, but then maybe I think she had benefited with that slight loop rate. In the first cycle, I had given her a dual trigger with loop rate as well as HCG. So she had that blast. The second cycle, because of long protocol, I couldn't give her loop ride. I gave her only HCG, and to my surprise, it was all empty follicles. So because it was empty follicles, obviously she will have some trust issues. First cycle also embryos were not great. She had a lot of confusion. She went to another center after this cycle. There also again they used biosimilars, fertilization failure. She didn't have any embryos. And finally she came back to me. I told her, see, we have done like almost 4 cycles now. Whatever embryos we have in that cycle where we use Gonalef, we'll transfer and we'll leave the rest to our luck and see what happens. And we did the embryo transfer, and she conceived, and now she is 37 weeks. I'm going to deliver her tomorrow. I just wanted to share this experience. So after that, we were also a startup center. Initially, as you told, the patients who came to us were all looking for budget. So we were using biosimilars. But then after these few little experiences in which when we used Gonalef, the blast rate, the success was better, we started convincing the patient that 10,000, 20,000 extra cost, if it's going to yield them the pregnancy, they are much more happy than spending 1.5 lakhs for no benefit. So patients are also now accepting, and we are completely using this protocol, and touchwood, it's been like 60% success in our center so far.
So that was a wonderful input, Nivedita. I would wish the other panelists also can give their experience or share a case which they had like this before. There are so many of them. Dr. Niket, you want to share something? I think no. So Dr. Christos, I want to ask you that you don't tell your embryologist what gonadotrophin you have used in this patient. And as soon as he or she sees the eggs, do they ever comment, oh, these are beautiful eggs, or there is vacuole, or they're granulated, or the eggs are not M2, they are less of M2s, more of GVs? And have you ever thought of comparing that with what gonadotrophin I have used?
We have done it across all gonadotrophin groups. And yeah, like in everyday practice, whenever we're looking at patients, we're always commenting on, what type of eggs we have retrieved and whether, we have a good maturation ratio, whether the eggs seem to be of good morphology, and all the other things that you mentioned in terms of quality characteristics of the eggs, which are not many. So you can actually grab and whatever you can from the scientists. So we have done studies where we have looked at the quality of the oocytes and the embryos, but these are again are retrospective studies, and we haven't published them. It's just more for our own center. And we have observed that, for example, with biosimilars, things are not as good. But the reason why we were, and we still are, very reluctant to draw conclusions from this comparison is because in many cases, the biosimilars would be used for like when everything else has failed and when the patient has had too many cycles, and then we give biosimilars. So that is obviously something you need to take into account when you're extracting and drawing conclusions. So we always saw something was there, but we were never convinced that it's a true finding on the basis of the selection bias that's there. But then if you combine that with, as I said, the randomized controlled trial, the evidence from the randomized controlled trials, then all of a sudden you can start seeing that it might not be all selection bias after all. There might be something else there. Yeah, look, the more we look, the more we find. And we're trying now to devise new studies where, again, either they're going to be prospective or because we actually have a number of other RCTs running right now at the cycle, I'm trying to find a new master student to analyze the data by doing a bit more advanced statistical analysis, trying to make them comparable with propensity score matching and things like that. So hopefully in the next few months, we'll have something more credible to share. But yeah, as you said, the observation is always there. It's just whether you believe it or not, on the basis of the quality of the evidence you have.
Yes. So even some of the embryologists are in the habit of now asking that what was the stimulation? What drug did you use? So maybe they are also a little bit convinced that they are happy when they get the good quality eggs from the originators.
Do we have any? We don't have any embryologists with us today in the panel.
Not really.
No, we only have doctors. That's okay. But it would be great if we heard some more experiences, from the other colleagues. I think it's very important to discuss the experiences we have, and I'm very, very thankful to all of you who already have shared their experiences. So is there someone else who would like to contribute to the discussion?
Yeah, this is Dr. Smriti here, sir. So I would just like to discuss about the reproducibility concerns because India, as being a poor resource setting, we sometimes have a problem with cold storage also. And I don't think there is any biosimilar which tells us that it will remain stable at a room temperature or when the cold chain fails. Right. So I have asked our representatives also, if they have any product which can remain stable even if the cold chain is not working or in the a storage facility. So I don't think nobody claims the same as Gonalef. There is nobody claiming that it will remain stable for 1 month at 25 degrees Celsius as Gonalef claims. So I have seen the reproducibility problems, and I have seen some patients getting good results, some patients not getting good results. So that is the main problem, the consistency, the reproducibility. So we are sticking on to Gonalef for the last 10 years, and I'm getting very good results.
Excellent. That is an excellent point. Again, there has been so many epidemiological examples where very good medication, when they were rolled out in the field, we saw they were not actually behaving in the same way. And the main reason was, as you said, how they were maintained, whether they were proper maintenance and all that. So it's not about what the RCTs can tell us only, but it's about how the actual product can be used in the field, in real world scenarios. And as you said, in many situations, you can have this type of failures in equipment. Therefore, you need to make sure you have some confidence that you will not lose your whole batch of medicine, or the patient can be reassured that the medicine will still do what it's supposed to do. No, that's an excellent point. Thank you.
Hello, Dr. Christos. This is Dr. Shilpa here. Hi.
Hello.
So I have a question, and this is from my experience of using Gonalef, that despite giving Gonalef, there have been a couple of patients who have had a very low M2 conversion rate. And this is despite triggering the patient at the right time and giving dual trigger. So from your experience, I just would want to know that for this kind of patients, do you usually start with a combination of LH right from the beginning of the cycle for patients who have had many number of immature oocytes the previous cycle?
Thank you. So again, in my diagnostic routine, thank you for the question, an excellent question. So in my algorithm, whenever I'm evaluating this type of scenarios, I'm always having a very combined approach where I look at that specific patient, I look at the stimulation, and I look at the history. So if, for example, the patient previously has been getting excellent maturation rates with more or less the same protocol or the same triggering signal triggering, then in many cases, I will say, look, this was not a great cycle for reasons we might not understand. In some cases, that might have to do with the medication, the batch, how they were maintained, whether, for example, the trigger, the ACG, or the triptorelin or whatever else you're using might have not been affected or might have not even been injected properly. So there's a number of things that could have gone wrong, and that cycle, unfortunately, might have resulted into. So there are these type of coincidental outcomes, and there are the outcomes that are more systematic. And the things that I look at, obviously, as you mentioned, dual trigger is something that definitely I use in scenarios like these. And in some scenarios, I've seen that some patients might react better to Ovidrel, to recombinant human ACG compared to the actually urinary, and in some other patients might be the opposite. Okay, so these things are things you try. Another thing I always do is look at not the BMI, but the body weight of the patient. If the patient is particularly big, she's like more than 100 kilos, then I will consider potentially increasing the dose. And in other scenarios, again, depending on whether I feel that we have entered too soon, in some cases we observe we get a lot of M1s and we get like what we call the M1 to M2s, the late M2s. In those scenarios, if we were to do a new cycle, I would probably push my egg collection to 38 hours. And we've done a study where we have looked like between 34 and 38 hours, and the incidence of essentially ovulation was extremely low. So this would be, let's say, my first line of attack. Then I agree with you, and particularly when you don't have the luxury of doing one thing at a time, and you want to make sure you have covered all bases, yes, starting with a late activity from the beginning is something that there is evidence that it could make a difference. So it is, something that I will use, trying to, again, minimize the chances that we'll have such a devastating outcome or, such a bad outcome. Particularly when you, as you said, the patients cannot just stay with you for 5 cycles until you find out what's the problem. You just need to make sure that you mitigate the risk of that problem happening again. So in those scenarios, you just have to have a combined approach, explain your rationale to the patient, say, I'm not entirely sure why this has happened, but I'll do this. This is my strategy in order to mitigate or to minimize the risk of it happening again.
And thank you very much. And would you suggest an increase in the dose of recombinant HCG and the agonist trigger in such
depending in most cases, depending on the weight? So if, for example, someone is like 60 kilos, I don't think you need to give more than 250 micrograms of ACG. Having said that, again, as I said, it's probably a reactive approach. I would ask the woman after she gets the ACG the next morning to come and have bloods and see whether the bloods have started actually working the way I would expect to be working. If the woman is a bit heavier, like more than 90 or 95 kilos, then in many cases, I would consider increasing the dose or potentially adding, let's say, and I know it's too much, but sometimes we do things again to minimize the risks. You have the Ovidrel, for example, and then you might add some Pregno and also have the Decapeptyl there just to make sure that all different, aspects have been covered, all bases have been covered, and the patient can never look back and say, oh, you didn't do enough. Well, I did more than enough. And if again, unfortunately, the issue is there, that means that it's irrespective of what you do. It might be an LH receptor issue. I've had a patient a few years back where essentially that was her main issue. And we actually we send her bloods for genetics. And we found that she had a specific mutation in the LH receptor that essentially made her almost, impossible to respond and to bind and create what it needs to create in terms of ovulation and the maturation, resume the meiosis.
All right. Thank you very much.
Yeah, so they say for the obese patients, instead of giving the subcutaneous HCG, it is better to take a guide bore needle and inject intramuscular deep inside the urinary HCG and 10,000 units to get the best outcome. Because and especially patients with bariatric surgery also, where there could be an absorption will not be very normal like any person, it could be a little erratic, and we can salvage the more M2 sites in such patients this way.
That's an interesting tip. I don't have any experience, but that's something I might give a try next time I have these challenges.
Yes, the subcutaneous absorption. Also, the use of this originators in the advanced age females versus the biosimilars. So supposing you are saying just 2 or 3 follicles, would you still pump in more injections, or you would just think of giving a minimal dose of 150 to 25 to this female of just recombinant FSH and let the follicle then grow on its own? Or that is the strategy that 40 plus we are using now more and more.
Yeah. Look, I do agree with you. I think that you cannot stimulate follicles that are not there. So if you give 500 or 600 or 300 units, especially if that woman, does not need them, you probably, the receptors have already been saturated. One thing I do, again, the evidence is not, let's say, evidence that no one can challenge. But I do think that in women of advanced age, adding LH might actually be useful and might make a difference. But I do agree with you that particularly high doses in women of advanced age compared with obviously poor ovarian reserve are certainly not beneficial, and they might even be detrimental. So I do agree with your approach. The only thing I do different is I also add usually 75 units of recombinant LH because I think it does help in the quality of the eggs you retrieve.
So the younger patients, it's only the recombinant FSH you use till the end if the response is good. You never add any amount of LH.
Well, I wouldn't say never, obviously. You individualize, as we know, one thing we always look. I'm not particularly concerned with whether the LH, for example, becomes less than 1.4 or less than 1, depending on the lab you have. I'm more concerned when I see that the growth of the estradiol becomes stagnant and essentially plateaus in those situations. I would certainly add LH. And there are some really very impressive examples, and like my trainees, my CRI trainees, we discuss them, where you can see how a woman has already had 8 days of injections and she seems to sort of be stuck. And then you see her again 2 days later and it's not much different. And then you all of a sudden add LH, and you don't have to add that much of an LH. Like 75 units for most women would be enough. Obviously, if it's a bigger individual, then you might have to go to 150. And then all of a sudden you see, almost the follicles blooming. It's very impressive. That's not very common, but it is common enough that I think all of us will have a few similar stories to tell. So FSH, and as I said, recombinant FSH is definitely my first line my first line gonadotrophin. And in most cases, I would probably stick to FSH only, unless there are certain signals like the ones I mentioned, where then I would consider mixing up with other types of gonadotrophin.
Any other questions from the panelists? So Dr. Christos, my question again to you, that they are transferred in a frozen cycle, the blastocyst from the biosimilar, blastocyst from the gonadotrophin. Why is there more implantation and more pregnancy rate with the originator versus the biosimilars in a frozen cycle also?
I think that's a great question. And it is something that we still need to prove. I mean, the obvious answer is the embryo quality. And I think your study has showed that. And it would be great if we had a prospective or randomized study showing the same thing. But again, it essentially, until someone proves that very, very clearly with a study that has very few limitations, if any, there's always going to be the question of what is the issue. And there are some studies, including studies with biosimilars, that have suggested that in actually the frozen embryo transfer cycle, the implantation rates or the pregnancy rates are very comparable. And then they theorize or they hypothesize that it might be that the biosimilars affect the endometrium differently. That's why I'm saying in the literature does not uniformly point to one direction. So to me, it's very fascinating to try and solve this kind of riddle, especially when the literature very clearly points the direction that there is an issue. And many people say, well, these randomized controlled trials are biased and might not be as methodologically rigorous as you would expect. But then the interesting argument is that all these RCTs have been designed and performed by companies who market and own biosimilars. None of the 5 RCTs that I showed you has been designed or performed by Merck.
Understood.
So it's rather you like assuming that someone would like to, let's say, skew the results. Obviously, I don't think that anyone would ever do that because the reputational risks are far too high. So no one would do that. But even if you are very, very suspicious and you're like, someone tampered with the results and what we are observing is not true, then I would say, as these data were essentially produced, collected, managed by companies that actually produce biosimilars, if anything, one would expect that the results would be shifted to favor the biosimilars. And that's not the case. And that's why I'm saying I don't think that any foul play happens. And, I do think these are very high quality studies. There is a very, very robust way of actually ensuring that the quality control is at the highest level. So I don't think anything like out of the ordinary or unethical has occurred. But even for some of us or some of, of the audience that might think that there's something suspicious, and how they tend to say that the industry and pharma always will bend the rules and all that. This is essentially a very clear example of the opposite, that, the results were produced and were published, regardless of the fact that for each individual study, there was a trend that it actually leads to lower live birth rates. And for each individual study, that trend was there. None of the individual studies showed a difference, but then that's the power and that's the beauty of meta-analysis, that when you combine them, you can actually find and see differences that are not visible with just individual RCTs.
So there is a question from Dr. P.R. Das for you, Dr. Christos. The question is, biosimilars also claim to be produced by the recombinant technology. Ideally, there should not be any difference. However, we find differences clinically. What may be the probable reason?
Yeah. So as I sort of alluded to in the beginning, well, yes, but there are different cell cultures. They're not the same cell lines. And essentially, it almost as if we have 2 factories, if I was to give like an example, and one factory has been there and has been producing the same type of product forever. And then someone goes and inspects the factory, and based on their recollection, they're trying to do, and based on the booklet of the product, they're trying to make a similar production line, trying to emulate exactly what's happening in the factory. Well, the end product will look similar, but will never be identical and would not be as similar. There are so many other molecules that are part of the eventual product, and that they're part of gonal-F, and that affect how the actual product and how the gonadotrophin will act and will interact with its receptors, that you cannot fully replicate. And that's why these cell lines are so valuable. And companies like Merck or like MSD or Organo now do their absolute best to make sure they're properly maintained and they continue to produce the same product they started 30 years ago.
Absolutely. So now I have Dr. Ruqayya Ashik asking, is there any role of adding growth hormone along with gonal-F for low reserve patients?
This is, again, a very intriguing question. This is a very expensive treatment, gonal-F. I'm not sure whether it's expensive in India, but in Australia, it's very, very expensive. We're talking about thousands and thousands of dollars, for which the evidence of efficacy are very, let's say, suspicious. And by suspicious, what do I mean? There is obviously randomized controlled trials that suggest that, yes, there is an effect. And there are randomized controlled trials that have been pulled in meta-analysis, and also the effect is there. So that cannot be overlooked. There's definitely something there. The only problem is that the methodological quality of the included studies is not of the highest standard, and that makes you a bit skeptical. And the other important bit is the poor responders that have been included in the different studies are so heterogeneous, you struggle to see how they can be combined. So that's my comment on the background and on the literature. So is this something, do I think that growth hormone might be beneficial for some patients? I think that it might be beneficial for some patients. The problem is, again, being a clinician scientist or be a clinician who every day treats patients, but at the same time trying to always research and find the question. I need to find who are these patients that actually can most benefit. And I think that should be, the goal of any scientific or medical endeavor. Always make sure that you know which medication works best for which patient. So that's something that we haven't found yet. So my general answer to your question would be probably not universally, but definitely I would consider adding it to selected patients, especially after I discuss with them the pros and cons and the uncertainty around whether it would help or not. As I said, the cost in Australia is a major consideration because it's not covered by Medicare. And the other thing that I would like just to raise is that I've seen, and from unfortunately colleagues as well, using growth hormone in women that, for example, are very overweight or have very high diabetic or insulin resistance. In those situations, I probably am very, very skeptical, and I think that is a very bad idea because you don't know whether growth hormone could help, but you do know that by adding growth hormone, you're aggravating the insulin resistance and the diabetes tremendously, which means you're probably doing more harm than good, or at least, there is a good argument there to be made. So I'm always very careful whenever I'm discussing these types of interventions with my trainees, but also with my patients, to make sure I have a very balanced representation. So that's my view. Yes, but only in selected cases. I'm not sure, what's your opinion, Dr. Patel?
I have been using growth hormone, and I would also believe that sometimes it harms the patient, especially in the later part. We do not know, suddenly the estradiol goes up, premature utilization. But initially 4 days prior to stimulation, 4 units, and then increasing 4 to 8 continuously, what I have used. But in one patient, I had a severe premature luteinization when I had used it around the 16 size follicles. So it can do harm to certain patients. Another question Dr. Leena Yadav asked, how much dose of growth hormone should be added and from which day of stimulation?
Again, if you review the literature, it's all over the place. You can see 4 international units, you can see 12 international units every second day, everything. You can see based on kilograms. What we use here, and again, that's not evidence-based, or at least it's not as evidence-based as I would like it to be. It's 4 international units daily, usually from day 2 or 3 of stimulation. So fairly early, not as early as you, Dr. Patel, where you're putting it, even before you start the stimulation. So that's an interesting concept, and would be, very, very keen to see whether it would make a difference. And we usually add it up until not the very end, but probably a day or 2 before we actually trigger stimulation. I personally, and again, I do not have a huge number of cases, probably are less than 100 in my personal practice that I've used growth hormone. I have never experienced, thankfully, premature luteinization like you have. So maybe it's because, as I say, we stop it a couple of days before triggering final oocyte maturation. I don't know, but yeah, that's the protocol we use in my clinic.
Okay, thank you, Dr. Christos. There is a question from Dr. Smriti. Is there any role of measuring FSH in late follicular phase to prevent premature progesterone rise? Yes.
So that's obviously, as you know, it's a topic of great affection for me. It has been an area where I've been researching for many, many years. So what I suspect Dr. Smriti is actually suggesting is what we and others like Hum and Fatemi have suggested, that when you have big follicles, the stronger you stimulate them, the more progesterone will actually produce. Therefore, if you have very high FSH, that is likely to push them a bit harder to produce progesterone. I wouldn't be as keen to measure FSH. That's not actually I'm doing on a routine basis, but I do measure the progesterone. And when there is a risk, a high risk, then there's obviously a few things you can do. If you're invested into doing a fresh transfer, then you can, and you see that the progesterone creeps up, then you can do a couple of things. You can try and reduce a bit the FSH dose. Still, probably it's going to be enough. I would be very skeptical about adding any type of LH or ACT activity, because one thing we have seen very, very clearly in our studies is that LH and ACG is actually a very potent steroidogenic stimulator, particularly in stimulant, particularly in the bigger follicles. So I would be very, very skeptical. And I say that because many years ago, there was a trend, and there were a few publications that were theorizing on how adding ACG might actually lower the progesterone. At that point in time, I recall having the discussions with the company that was producing that, and I said, what you're saying makes no sense because there's no physiological way for that to happen. Obviously, there were others that had the opposite opinion, and I actually asked them for funding to do a study to prove them wrong. They didn't give me the money, and that's fine. It's absolutely fine. They gave it to, the other like clinician scientists who were proposing an alternative model. But unfortunately for them, the study that was published later showed very clearly that the more ACG you add, the higher the progesterone. So I don't measure routinely FSH. I do measure progesterone routinely, and not just in the late, from the beginning. And whenever I'm concerned, obviously I can always freeze all, and I'm very comfortable with freezing all. But in some cases that might not be an option, or that might not be what the patient wants. Then I would either lower the FSH or potentially think of triggering slightly earlier than what I'm usually doing.
Yeah, Professor Human Fatem is, he just stops at 20 IU of FSH. He doesn't give FSH at all for the next day. And we have presented that. So HCG, yes, only HCG using for not a fresh transfer, but increasing the size of the follicles. I have seen that in number of patients where nothing is working, the FSH, HMG, you just give, I give 1250 IU of HCG for 4 days and call after 4 days, and to our surprise, we see follicles turning into blastocyst also, but not as a routine in tricky patients.
Yeah, of course. It's individualized.
Yeah, there is a question anonymously asked, what is the protocol of ovarian stimulation which can be given to a patient of luteal phase deficiency and a poor AMH?
Again, a very, very interesting question, very, very specific. Well, the luteal phase deficiency, if we're talking about what many patients come to the clinic with, I still have my very strong reservations on how frequent and how common that is. Many patients come and have been self-diagnosed with luteal phase deficiency, that then when we actually look at the kinetics of progesterone during that second phase, everything is just fine. So, but assuming you have done your proper follow-up and testing and you see that these things are actually occurring, then
Molina, sorry, somebody else, I'll just inform.
અને ફેમિલીમાં કોઈને મમ્મી પપ્પાને ડાયાબિટીસ કે કશું કોઈ અત્યારે દવા
Sorry, we
ગોળી
have a...
Madam, we'll mute her, madam.
2 મહિનાથી જ હમણાં અનિયમિત થયું.
Molina, unmute your phone, Molina. Unmute.
Madam, we are muted it. Thank you.
Yeah, okay. So what is the protocol for ovarian stimulation? Again, a very, very interesting question. Probably not a very high dose. Why? Because the higher the dose you give, the higher the estradiol you'll end up. And the more the estradiol you have, the more profound the suppression of LH will be during the luteal phase. So that's something you would like to avoid. So I would probably try and, not push the follicles to a very high level, and would try to have a very balanced and measured ovarian stimulation, trigger them with probably either ACG, urinary, or recombinant, and hopefully that would be enough to essentially counter any luteal phase deficiency. Obviously, you can still go ahead and measure progesterone during the luteal phase, and if you see that you need to add up some ACG or some LH, that's something that has been proposed by colleagues. Human again has published and has presented data on this. I find this a very, very intriguing approach, especially and potentially useful when you're very, very invested in doing a fresh embryo transfer. Thankfully, in Australia, many patients now are very open to doing frozen embryo transfers, and they don't complain at all. So all these scenarios that my colleagues are presenting, to me, they seem a bit problems that are no longer there for me, a bit for first world problems in a way. And whenever you, especially when you are allowed and when you can do it, transition to I don't have necessarily to do a fresh embryo transfer, then all sorts of new possibilities actually arise. So I'm actually now in the process of publishing an article in Human Reproduction about all these new models of care and stimulation protocols that are feasible when you do not necessarily want to do or need to do a fresh embryo transfer.
Okay. So there's Dr. Leena Yadav who is asking, can the antagonist be added as early as day 4 of stimulation to avoid premature LH surge?
Certainly, if the estrogen is high enough, certainly. That means obviously that you screen the patient on day 4. And I'm not sure whether you did that routinely. I mean, you can do it if, for example, in the previous cycle, things got out of hand. But in my clinic, we see all patients on day 5 of stimulation, and 99% of them, not 99, 95% of them would start on day 5 if they have more than 500 picograms per mil. If they are, if they are lower, then obviously we'll just wait until they have a more substantial follicular response. Yeah, definitely. It's just that in my clinic, we rarely will bring them on day 4. It will be on day 4 if, for example, day 5 is on a Saturday and they're going away and they want to have the blood test on a Friday. But yeah, I would be very, very open to starting antagonist earlier, 100%.
So here, I would like to ask, the study that I presented was presented as a poster in the Indian Division Society by Dr. Molina Patel. And she was asked a lot of questions by the judges. So I'll ask Molina to put up the questions what the judges have asked her regarding this study which I presented over here. Molina there? No, he's not there. So in the meantime,
I think Molina got scared because we told her off a bit with her phone.
I think so.
Yeah, I think she's there. She had just unmuted herself, and for a moment, she's there.
Yeah, you can ask her that. Because she was grilled by the judges. She told me that these are the questions they asked. Why the biosimilar was not giving good result? Why didn't you add LH if it was not giving good result? There were so many questions that they were asking. If she can share it, that would be wonderful. Till then, I'll ask another question. The concept of terminal T-half considering recombinant LH addition.
Yeah. So if we're talking about the LH activity, we know that the recombinant LH has a shorter half-life, and that can be advantageous, and that can be not as advantageous. It depends on how you want to see things. There are studies that have published supporting differences. We tend to think that having a longer half-life, therefore a more sustained activity, is better. But at the same time, there are some very interesting studies suggesting how, for example, the recombinant LH activates a different pathway in the cells compared to ACG, which activates pro-apoptotic signals, and then that can lead to inferior eggs. These are very interesting theories. I don't think we have fully essentially clarified where things are. We don't have an answer for everything, but it's definitely investigating the differences at the molecular level is a step to the right direction to see what are the differences. And if we know what are the differences, then we can start implementing certain strategies so that we know that we're giving the right product to the right patient. You're muted.
You're on mute. You're on mute.
So what is your opinion regarding very low LH on the day of progesterone start in an FET cycle?
Are we talking, I would like some clarification by, I think it's Dr. Smirty. Are we talking about a natural cycle, a modified natural cycle, an HRT cycle?
It's an agonist downregulated cycle. It's an HRT cycle, it's an agonist downregulation.
Okay, can I ask why do you feel the need, again, and this is obviously a genuine question, why do you feel the need to downregulate? Is it a scheduling thing? Or do you feel, for example, that we might have escape ovulation? Why do you feel the need to downregulate in an HRT cycle?
The idea that it might have an escape ovulation, yes. And maybe we are landing with very high LH, like the hormones which are not very desirable.
My experience, and especially not here in Australia as much, but in Greece, where I was also practicing before coming to Australia, was that it's extremely rare. It's not, of course, we've seen it, but it's not as common. And I feel that if you are giving 100 women Cineral, or any other type of downregulation to prevent two of them potentially from having escape ovulation, that might not be very cost effective in a way. And you might putting many women to a lot of trouble for no real risk. And so that is, my view. I wouldn't necessarily be very concerned if the LH was very low. Why? Because essentially you did that. We did that. I don't think that the LH would affect the lining in the way that has been suggested before. And we do have evidence, not from HRT cycles, because here in Australia, ever since the data came out on potential, increasing, doubling the risk of preeclampsia and pregnancy-induced hypertension with HRT cycles, whenever we can have, a corpus luteum there, either with a natural or a modified natural, or even with an ovulation induction using FSH, we always try that, and we're no longer doing HRTs. HRTs we would reserve only for menopausal women, either women with premature ovarian insufficiency when they cannot ovulate themselves. So that's what we do now, and we actually have excellent results. We even have, we think now that we have even better results than what we had when we were doing more, more regularly the HRT cycles. So that might be, something I would like you to consider, moving away from HRT cycles and going either to modified natural cycles where women would be triggered, or to natural cycles. I feel the results there are excellent, and they could very well be better than HRT. Dr. Patel, I'm sorry,
you're in mute, madam.
So nowadays we are shifting more towards a natural cycle FET transfer, but do you modify it a little bit by giving HCG and then starting the progesterone from the next day, or no progesterone at all?
Again, sometimes it depends. Sometimes we will modify it, especially when, for example, for convenience purposes, she has a very good lining. She has a nice follicle of 18, 19 millimeters, and I don't want her to ovulate, let's say, on a Monday or a Tuesday, and having to do a transfer during the weekend. Then I might say, let's trigger her on a Saturday and or on a Friday, and therefore we'll do like the transfer on a Friday. And we've seen that this actually works great. Why? Because there are some individuals where if you leave them to surge on their own, they have this very, very weird LH surge kinetic, where it never goes like all the way up and then comes down. It might go all the way up to 22, and then the next day is 27, and then the next day is 25, and you're like, where actually is the LH surge? And what I always do, and again, we have some very interesting data, hopefully will be published within the next couple of months in Human Reproduction. We're in the process of review. And what I always do is not actually look at the LH surge. I look at the progesterone concentrations. And the reason for that is because at the end of the day, what the lining can see is progesterone. The lining cannot, yes, there are LH receptors, we know that, but I don't think they're as important. So if you can properly ascertain the exposure of the lining to the progesterone, you're far more likely to hit the window of implantation rather than just looking at the late surges. And as I said, we have data to back this up. Obviously, I cannot actually tell you more about this, but in the next few, hopefully in the next month or two, you'll see a nice publication in Human Reproduction that is going to very clearly show and support what I'm just telling you now.
Absolutely. Even I feel that progesterone level. And what is your cutoff, if I may ask?
So, like a trick I have, and this is now what I'm teaching to my CRA trainees, is if you really want to know when ovulation happened, you should expect, I almost do it always retrospectively. And by that, I mean, obviously we know before ovulation, the progesterone goes up a bit. We know that on ovulation, probably it's going to be around 2 to 3 nanomoles per liter. And then the day after ovulation has happened, so I actually do measure the blood the day after ovulation has happened, it should be somewhere between 7.5 to 12.5 nanomoles. On average, 10, but it's never 10. Sometimes it will be 7, 8, 9. And if I see that 8 or 9, I always say, okay, ovulation day was yesterday, count 5 days when we're doing blastocysts, and let's put it back 5 days later. And we have seen that has given us about like a 10 to 12% relative increase. So for example, if the pregnancy rates were 40%, they went to 44. So it's not a huge difference, but again, it's all these little things that eventually will make your program stand out because you're going to have better results and patients will be happy. That's my MO, that's my methodology.
So one of the participants, I think Dr. Molina, is asking, do you ever use recombinant LH in PCO patients?
Extremely rarely, because as you know, many of them will have an abundance of LH in their system. In most cases, we'll try to see what we can do to just break the LH, lower the LH, so that the follicles can be more responsive.
Okay. And there is another question that if there is suboptimal from Shilpa Reddy, that a suboptimal follicular response on day 6 stimulation is, will you increase the FSH or you will add LH?
Sometimes both, depending again on what dose I have. If I have a dose that I consider is saturating the FSH receptors, if I have, for example, in a fairly slim woman, like 250 units, I don't think that making it 350 would make a huge difference. And then I would also observe the LH levels, and I would observe the estrogen levels. So if these things seem to be fairly low, then in my eyes, LH would probably be more beneficial than adding FSH. If on the other hand, you have a woman who is like 80 kilos and had an AMH of like 18, and you give her 250 units, that might not be good enough. Sometimes I will also ascertain the FSH level, the FSH level. And if that's lower than 15, I will certainly increase the dose of FSH.
So you believe in measuring the FSH level in the follicular phase when the follicles have not grown as per the expectation, and to take a decision whether to add LH or whether to increase FSH. So if FSH is less than 15, you wouldn't mind increasing FSH. But if the FSH is already high, in that scenario, you would want to add LH rather than increase the FSH. Brilliant tip, which I have not heard of. I think it's very, very interesting.
And the reason, Dr. Patel, I do this is because again, instead of assuming, it's always better to knowing. So by doing that, I cover for the following things. First, I might actually be underdosing my patient. B, the patient might not be taking the injection properly. And then you can see that. So you can catch these little mistakes. And then if we see abnormally low FSHs, I actually have my nurses to see how the patient, by a Zoom, now with Zoom is very easy, to see how the patient is doing the injection and make sure they're very well trained. And at the same time, it might be that the FSH, there are batch-to-batch differences or issues that have to do with, as we've discussed, in certain scenarios, maintenance and how things have been preserved. So you get more information, and that allows you to, again, inform your practice and inform your essentially choices, your therapeutic choices.
So there is last question, I think, or if we can take more. Dr. Niket Patel has asked that if the LH levels are high from the day 1, would you want to add an antagonist earlier in this patient or wait till day 6?
So she mentions that if the patient has a high LH level on day 1. So what I'm pretty sure has been observed is we do know that as soon as the estrogen goes up, the first reaction of the LH is to go down. That's the natural reaction of the pituitary. It's the negative feedback. The estrogen has to stay up for a prolonged time, for days, in order for the LH start creeping up and essentially giving us the LH surge. So no, measuring LH in the beginning of the cycle and seeing it as elevated, I would not be concerned that that patient would have an LH surge. I would be more concerned that the patient, if I've given her, let's say, if she's PCO and I've given her 125 or 150 units, I would be more concerned that this might not actually do anything. So I might bring her back after 3 or 4 days just to see whether something has started moving, or maybe I need to sort of, increase the dose a bit. But LH, LH surge or LH rise would not be my concern in these patients, particularly during the early phase, because as I said, it's almost always that when the follicles start producing estrogen, that estrogen will suppress initially the LH.
Yeah, so that is the gonadotrophin surge attenuating factor which comes into the action. And initial 5 days, we want the LH to go down. If it rises,
Exactly.
we are worried that this patient will need LH supplementation rather than not supplementing it. So that is one. And the 24 hours recovery after giving an antagonist, if the LH goes down and returns back to more than 50% of the previous level, that patient is good without LH supplementation. But after giving the first antagonist dose, if the LH remains persistently low, then again LH supplementation would be advisable in this patient. That's an interesting article from Cole, Israel, where they've done this. Very interesting. This is very, very interesting tip. Some of them we got, Dr. Sisters, were very interesting. Last question again I have from Leena Yadav. Is there a role of adding antagonist in an IUI cycle if the baseline LH of the patient is more than 15 on day 2 of menstrual cycle?
I don't think, I don't have the experience to answer that question. My gut feeling on the basis of reproductive physiology is probably not. I would still monitor, obviously, and see if the LH starts creeping up, then it is certainly worth considering. But my initial reaction, as I said, I do not have all that wealth of information. I rarely add antagonists in IUI cycles. In most cases, women would do fine without. But I would think from a reproductive physiology perspective that probably it wouldn't be needed, unless it's an exceptional case. And probably in that case, you would be able to pick up a bit later during ovarian stimulation or ovulation induction, not based on the basal LH.
So I think we don't have any more questions and you wanted to leave at 4:30 p.m. Indian time. Dr. Someshwar, can you come in?
Yes, madam.
Can I just say that this has been a truly excellent session. I've really thoroughly enjoyed the questions and the interaction. So I'm actually very, very happy that, and as we discussed with Dr. Patel, I try to share my experience and whatever tips I have, but I think I've picked up some very interesting tips from my Indian colleagues. So thank you for that.
Thank you so much. So I need to mention that there's a 5.5-hour time zone difference between India and Sydney. So it's almost 10 p.m. at Sydney for Dr. Venitas, and it has been really wonderful to have you despite this time gap. So we thank you very much for your presentation, which was really comprehensive and beautiful lecture, and also very patiently addressing all the queries from participants with taking care of all the aspects. So thank you very much, Dr. Venitas. It's wonderful to have you. Looking forward for more such meetings in future. Thank you so much.
Thank you. The pleasure was all mine. And thank you to Dr. Patel as well.
Yeah, and thank you, madam. Thank you for them for joining and sharing your unique experience from your center, comparing the Gonalef versus biosimilars, and also for your excellent moderation and China session. Thank you very much. Last but not the least, we will thank all the participants who have joined in on an afternoon working day and putting up all the relevant and important questions and making the session an interactive one. So we thank all the participants for joining in. So thank you very much. And we can conclude the session now.
Good night. Thank you so much.
Thank you, madam.
Good
Thank you
night.
very much.
Thank you. Enjoy the rest of your day. Thank you. Bye.
Thank you, Dr. Venitas. Thank you very much.